So, hello, I will be doing a presentation on multiple sclerosis. This is the case of Laurie. She's a 38-year-old woman with MS. She has been on Tecfidera for years. Reason for visiting the office is wanting to talk about starting Tysabri, which her neurologist has suggested, and she just wants some more information. And also, she thinks she has a sinus infection and wants a Z-Pack. So just an overview of multiple sclerosis. It is the most common immune-mediated inflammatory demyelinating disease of central nervous system. The cause is unknown, but the theory that is the widest in acceptance is that it is characterized by immune-mediated autoreactive lymphocytes. The presence of demyelinated plaques in CNS is the hallmark of MS. And then these lesions can be in optic nerves, spinal cord, brainstem, cerebellum, juxtacortical and preventricular white matter, but they also can be found in gray matter as well. The most prominent feature is these plaques or lesions that can be seen on MRI. So there are a couple subtypes of MS. One is called clinically isolated syndrome, which is a single episode of neurological symptom or an MRI plaque. And not all of these cases go on to develop MS. The next one is called relapsing remitting MS, which is the most common type. About 70% of cases are the relapsing remitting type, and it's characterized by periods of symptoms with complete recovery. Then there's also a type called secondary progressive MS, and which is sort of the next stage from relapsing remitting MS. Approximately 85% of patients with relapsing remitting disease go on to secondary progressive MS. And the fourth type is called primary progressive MS. It's kind of uncommon. Only about 10% of cases, they do not have remissions. Instead, it's sort of relentless neurological deterioration. As far as clinically, the symptoms you can see on the slide, there's many areas affected in the body. Common symptoms are sensory symptoms in limbs or face, unilateral vision loss, motor weakness, acute or subacute, diplopia, gait disturbances, balance problems. Lermite sign is an electric shock-like sensation that runs down the back and or limbs when you flex the neck. Vertigo, bladder problems, ataxia, pain. Onset typically is polysymptomatic. They can have many kinds of complaints, and the typical patient presents as a young adult. The peak is around 35 years old, and typically people present with 2 or more clinically distinct episodes of central nervous system dysfunction with at least partial resolution. Interestingly, there is a higher male to female ratio for MS diagnosis. It's approximately 2 to 1. And it also has an interesting geographic distribution. MS is rarely found along the equator. And the more north you go in both directions to the poles, the higher the incidence. There are some readings that I did that suggest that this geographic distribution is starting to change. More people are being diagnosed in sort of warmer areas as well, and maybe it's just better diagnostics. We don't really know yet. So the core requirement for diagnosing MS is the objective demonstration of central nervous system lesions in both space and time. And it can also be diagnosed clinically, alone or with a combination of MRI findings. So a correction for a mistake, the female to male ratio is 2 to 1, not male to female. So as you can see on the slide, this is what the MS plaques or lesions look like on MRI. But I won't be talking too much about these because mostly neurology will be interpreting MRI results and helping figure out the best possible treatment option for patients with MS. In the primary care setting, I think it's important that we know about these therapies, but I don't believe we will be the ones prescribing them because they are so specific and carry quite a bit of risk. But anyways, I'll explain a little bit about disease-modifying treatments for MS. So, as far as I know, there are 14 FDA-approved disease-modifying medications approved for MS treatment, and they are indicated for relapsing or primary progressive MS, regardless of age. And I was reading through some multiple sclerosis coalition suggestions, which is this document that goes over the most recent evidence and sort of steps and recommendations of what to do. And they suggest that a person should go on to a disease-modifying medication as soon as possible after they have had their first episode of neurologic symptoms, as well as MRI findings consistent with MS, and all other causes have been ruled out. And so this treatment with disease-modifying therapy should be continued indefinitely unless any of the following occur. So their side effects become intolerable. There are signs of severe adverse events. A person is unable to follow the recommended treatment regimen for whatever reason, or a more appropriate treatment becomes available. There are times when movement from one disease-modifying therapy to another is indicated, but it only should occur for medically appropriate reasons. So in these cases, if the evidence suggests that a medication is not providing adequate benefit, a different treatment that works by a different mechanism should be considered. And pre-existing medical conditions, current medications need to be considered. Patients with MS, their family members, and healthcare professionals, all need to be involved in these discussions. What the next step should be, because patients and providers have different tolerance for risks associated with these disease-modifying therapies. The medications are different in how they are given. Some are oral, some are IV injections, some are sub-Q or IM, some are like weekly or bi-weekly, every 4 weeks, such things. So you really should think about what's the best and most reasonable option for the patient. So I'll review Tecfidera briefly. This is the medicine that Laurie has been on for years for her MS. It is an oral medication. It started twice daily for 7 days at a lower dose, and then the maintenance dose is doubled, and that's twice daily indefinitely. As you can see, the cost is quite a bit, but I don't know as far as insurance coverage, but I assume that it is covered for these people because it's indicated. So it is this nuclear factor like 2 pathway that it is involved in. The mechanism of action is kind of unknown, but the researchers believe that it's involved in a cellular response to oxidative stress. It is immunomodulating, but it is not completely immunosuppressant. It is metabolized by esterases in the GI tract, which are in GI tract, blood, tissues, before it reaches systemic circulation, and it bypasses the P450 pathway. It's eliminated primarily by CO2 exhalation. The half-life is quite short, about 1 hour, and there's usually no circulating metabolite found in 24 hours after. The body weight, gender, and age don't require any dose adjustment according to the manufacturer's pamphlet. There are no interactions with oral contraceptives or aspirin seen in studies. The major side effects is something to talk about. So it is carcinogenic and causes mutations, impairment of fertility. So women of childbearing age really need to be counseled to not try to get pregnant on it. And if they do become pregnant, they should probably discontinue the medication uh, to avoid defects. Uh, the most serious side effect of this is PML, which is progressive multifocal leukoencephalopathy. It's a rare opportunistic brain infection, usually leads to death or severe disability. It is caused by a JC virus, um, and symptoms are progressive over days to weeks. Usually, it starts out as a weakness on one side of the body, clumsiness, disturbance of vision, changes in thinking, memory orientation, confusion, personality changes. Um, if this happens, people need, healthcare providers need to be notified, and patients need to be worked up to, make sure it's not PML. And if it is, therapy needs to be stopped. They need to be treated, mostly hospitalized. More side effects are, anaphylaxis angioedema, lymphopenia, so decreased lymphocyte count, but apparently does not impact the rest of the white counts. Liver injury, flushing, and GI reactions. So there were two clinical trials that demonstrated the efficacy and safety of Tecfidera, and they both included patients with MS who had had at least one relapse in the prior year, and they had demonstrated MRI lesions. So the first study showed 27% of patients relapsed in 2 years in Tecfidera group, compared to 46% in the placebo group. So pretty significant. The second study was a multi-year and multi-center study, and it showed similar results. Relapsing was 29% in Tecfidera group compared to 41% in placebo. Relative risk reduction was 34%. So it has been around for a while, and it is considered a medicine that helps stop the progression of MS. Okay, so let's talk now about Tysabri, also known as natalizumab. This is the medicine that Laurie has come into office to talk about. She has questions about it. Neurologist has suggested starting her on it. So Tysabri is indicated as a monotherapy for relapsing forms of MS, but it is also used in Crohn's disease. Mechanism of action is that the integrins bind to leukocytes on their counter receptors. And these integrins are in vascular endothelium, in GI. In MS, it is believed that the lesions occur because activated inflammatory cells, including T lymphocytes, cross blood-brain barrier. And this leukocyte migration across blood-brain barrier involves interaction between adhesion molecules and inflammatory cells and their receptors on endothelial cells of the vessels. So data from experimental animal models of MS demonstrated a reduction of leukocyte migration into brain parenchyma and reduction of plaque formation. So that's how it's supposed to work. It prevents T lymphocyte migration across blood-brain barrier. It is administered by IV infusion every 4 weeks. It takes about 1 hour for infusion, plus another hour after infusion for monitoring to make sure there are no bad side effects. It is very expensive. As you can see, one dose costs about $7,000. Um, it does take about 24 weeks to achieve steady state of Tysabri with every 4-week administration, and the clearance is about 11 days to get it out of your system. Increased body weight increases Tysabri clearance, so that's something to keep in mind with patients that are overweight. It is only available under a restricted prescribing program called Touch. There are very stringent rules for patient and for the providers. They have to sign a enrollment form, review educational materials, evaluate patient every 3 months, and then every 6 months after, determine every 6 months whether they should continue the therapy, and resubmit another authorization and questionnaire to the manufacturer every 6 months. And they have to report on side effects and etc. So we probably, I would assume, we won't be doing this in a primary care setting, but if our patients are on it, it's not a bad thing to know about these drugs. As far as side effects, again, PML, which I talked about in a previous slide, but it's especially risky if people have had prior treatment with immunosuppressants. Also, side effects is HSV, encephalitis, meningitis, retinal necrosis, liver toxicity. The infusions of monoclonal antibodies have a significant risk for anaphylaxis or hypersensitivity reactions, and also immunosuppression and infections. So I just wanted to go a little bit more into the overall risk of PML with natalizumab therapy. It's estimated to be about 4.1 in 1,000 patients. And also, the longer a patient is on natalizumab therapy, the higher their risk for PML becomes. I think they usually don't like to give it more than 2 years in a row, from what I have read. So monitoring would involve, CBC, liver functions, periodic MRIs, and there is some evidence showing that some sites that I read recommend anti-JVC antibody testing every 6 months for patients on natalizumab to see if they convert to being seropositive for JVC antibody. And if so, I guess they still continue treating them, but they just monitor them even more closely. And this anti-JVC antibody testing should not be used to diagnose PML because it's not the same thing. And also something to keep in mind, the signs and symptoms of PML, which I described in the previous slide, they are very similar to general signs and symptoms of people with MS. So sometimes it's difficult to distinguish. But again, this side effect of PML can be deadly. Also, when you discontinue Tysabri, people go into about 6 weeks later, they can go into this IRIS syndrome, which is called immune reconstitution inflammatory syndrome. And it's usually treated with high dose steroids, and some places said also mirtazapine, which is surprising to me. But again, this would probably be hospitalized patient, very ill. I don't think we will be dealing with it in an outpatient setting. So back to Laurie and sort of clinical reasoning and why she's here. So obviously I would talk to her about Tysabri and her concerns, but I also would like to discuss the sinus infection. So, she comes in complaining that she has sinus infection and she wants a Z-Pak, asking her how is she doing otherwise. She's okay. She has occasional muscle spasm, neuropathic pain, fatigue, depression. She was diagnosed with relapsing remitting MS at age 31. We know, treated with Tecfidera by neurologist. She has seasonal allergies and depression. Her mother is alive, has depression and osteoarthritis. Father is deceased. Coronary artery disease, COPD, lung cancer. Sister alive and well. Laurie is white, college graduate, works at a bank, not married, no children, lives alone. In her 30s, typical MS patient, female, um, up north, white, usually educated. She's on also gabapentin, baclofen, sertraline, Mirena, and Tylenol, and naproxen is needed for pain. She says she has allergies to penicillin, but that it's mostly diarrhea. So my plan would be to examine her, discuss Tysabri, and address her sinus infection. So as far as the sinus infection, I would want to know how long has she had her symptoms and to describe them. I would ask about sick contacts, fevers, any discharge from nose, coughing, sneezing, itchy eyes. I would also want to know what has been working at home so far, what has helped, what has she tried. And since she has history of seasonal allergies, I would ask her, does it feel similar to her allergies or does it feel different? Um, if she's a reliable patient and she's had sinus infections before, I'm sure she would be able to tell the difference. On physical exam, I guess I would just look for, redness, swelling in the nasal mucosa, inflammation, patchy, inflamed throat. I would examine her ears to make sure there's no ear infection. I would probably check her lymph nodes of the neck to see if they're not swollen. I guess on the differential diagnosis, I would consider common cold, allergic sinusitis, or acute or bacterial or viral sinusitis. So if she reported to me that she had any fevers or chills at home, malaise, purulent drainage from nose or cough, I would probably lean towards bacterial sinusitis, especially because she's at more risk for, a little more immunosuppression from Tecfidera. Um, with any of these disease modifying treatments for MS that work on immunomodulating pathways, you always are concerned if people do become infected, which they have greater chance of infections because of these treatments. You don't want to miss things. So I guess I would lean towards treating her because the benefit would far outweigh the risk of her getting really, really ill. And especially considering that perhaps she will start Tysabri in the near future, which is definitely very immunocompromising. She should definitely be treated for this sinusitis to prevent further complications. So I would probably order a CBC to see what her white count is, and knowing that Tecfidera lowers lymphocyte count, but it should not affect neutrophils or other white blood cells. I could order a CMP to see her other electrolytes, kidney and liver labs, but I would probably give her antibiotic without waiting for these results. I would talk to Laurie about Z-Pak, azithromycin not really being indicated for bacterial sinusitis because of potential for resistance. I would try to discuss with her allergy to penicillin and hear what her story is. If it was just a slight GI upset or was it a terrible, bouts of diarrhea. Then based on, her responses, if she's willing to try something besides a Z-Pak and had no anaphylaxis to penicillin, I would recommend a high dose of amoxicillin clavulanate, 2 grams and 125 milligrams extended release tabs orally twice a day for 7 days. And this was recommended from UpToDate for high-risk patients. If she's not willing to try this because of concerns for diarrhea, Sanford Guide suggests cefoxidim, 200 milligrams twice daily for patients that don't have anaphylaxis to penicillin but are allergic. She could also try saline nasal irrigation to relieve symptoms. I would recommend her buying one of those pre-made saline irrigation bottles from pharmacy rather than make her own tap water and salt neti pot irrigations at home because of her immunomodulating therapy that she's on with Tecfidera. I would not want her to introduce potential microorganisms into her sinuses by using tap water, and rinsing too much. So she could also try nasal decongestant, but references say no more than 3 days. And she could certainly try an oral allergy medication such as Allegra for symptom relief. Uh, I checked Lexicon for medication interactions with Tecfidera and the meds she's on. There were no concerns, no interactions notable to modified therapy except for sertraline and naproxen. Um, it's because of together they can decrease platelets. It was suggested to modify treatment. So, and I probably would also talk to Laurie about being cautious with Tylenol since Tecfidera can cause liver problems. All right, so I thought this cute mouse slide would give me a little distraction from all the seriousness. So, a little bit about these monoclonal antibodies, also known as MABs, because they all end in MAB. So, they work on molecular level and they're considered targeted because they have a molecular target, and they're considered biologic because they're manufactured from natural modified cell clones and therapies, mostly from mouse cells. So there are about 50 monoclonal antibodies and biologic drugs under licensed clinical use, and many more are under study. I think this is where the future is going as far as treatments for many of these. In oncology, it's huge. Any kind of autoimmune disorders, MS, rheumatoid arthritis, Crohn's, I think they're just going to explode in the future. These drugs stimulate or inhibit immune mechanisms based on how they are designed. They can selectively bind and destroy target cells by recruiting and triggering the cytolytic function or other components of immune system. And alternately, they can also bind to key proteins. It disrupts process that is essential for continued survival or growth of these target cells. They've also been used when you add like a chemotherapy molecule to this MAB, and then it goes directly to the targeted tumor cell and kills it. It's quite interesting. So the prefixes are here for you for your fun. So we start out with a mouse. The MOMAB is all mouse proteins. The ZMAB is chimeric, part human, part non-human, so mostly mouse still, but not quite. The ZUMAB is humanized. I don't really know what that means, but it's, I guess, mostly human, part non-human. And then MUMAB is all human. So as you can tell, it's best to be human, and it has the least hypersensitivity and anaphylaxis risk. The more human or humanized proteins you have in these drugs, the better to prevent infusion and hypersensitivity risks. So for Laurie's client teaching plan, I would treat Laurie for her sinus infection first before she starts her treatment with Tysabri because of immunosuppression and infections that are known side effects of that medication. She should not start Tysabri with an active infection because she will be immunosuppressed on natalizumab, and it certainly increases PML risk. I would also recommend that she has more discussions with her neurologist. I would be curious to know why he wants to switch her from Tecfidera to Tysabri. Tecfidera is pretty well tolerated, oral twice a day medication. This is IV every 4 weeks. I mean, maybe it's more convenient just to do it once a month as an infusion. I'm not sure what his thinking is as to why. Is it because Tecfidera is not effective anymore? Does she have more lesions on MRI that I don't know about? Or is it something else? Or is it her preference? I don't know. Since guidelines say that movement from one disease-modifying therapy to another should only occur for medically appropriate reasons, I guess it would be curious to know what those reasons are. And I would counsel Laurie that, if she starts this new therapy with Tysabri, she needs to report any new neurologic changes immediately and come in for evaluations since they can be serious, such as PML. She needs to be aware of increased risk for infections, liver problems, reactivations of serious herpes or zoster infections. She will need to have her counts, blood drawn and counts monitored periodically, and just discuss the risk and benefit of the switching to the new medication. And that's all I have for you. I hope it was helpful and not too boring. I learned a lot by researching this. Thanks. Bye.